Diagnosis is very important for the doctor how to plan the treatment. And the treatment plan is based on the findings with the history taking and afterward with the some other type of tests that patient is recommended to do. And this diagnosis should be looking into skin, especially when autonomic nervous system is involved and there's a damage to it and the paper mentioned about some of that and also there should be some type of diagnosis if the muscles and tendons are being affected, the joint ligaments, the bursae, menisci, cartilages, this which are all part of the soft tissue that might be damaged during the whiplash. Then internal organs would be also very important to look into, and especially if somebody who is in the severe trauma that hit the chest or abdomen to something or hit the floor, steering wheels, even the seat belts can damage the internal organs if the severity of the force is strong enough to do so. Then there should be some type of diagnosis to monitor and examine the nerve and nerve roots, and then definitely in the severe case, you are also try to examine the functionality of the brain to see that how stable the brain is, does it function well, and again in the report that we are reviewing, it is the an issue that the patient suffered and was ignored for some time, for years, until finally they look into the problem deeply and find out that the patient has the brain trauma. Beside the soft tissue damages that we need to examine, also the hard tissue like fractures and the broken bones would be, or compression would be something that we like to look into, and that happens very often with the physical trauma and whiplash also included. In order to better serve a patient in whiplash or trauma, it is better to have a better understanding of what the problem is with the patient and have a better diagnosis. And imaging is a tool that clinicians have to study the condition of the patient in more detail. And there are different tools in imaging, and each one of them has their own benefits and drawbacks. And for example, X-ray, which is very quick and can be done in many imaging centers and even in the small offices. And it is very good tool. It is a very good tool to study the fractures and but when somebody is studying the bones and which are connected by joints, uh, the alignment of the bones can also lead the radiologist or the clinician to see the any abnormalities might be existing in the joint, and then it leads the clinicians or it also radiologists to suggest for further studies and recommend that. CT scan, it is similar to X-ray, but it shows more detail and depth. And again, it tells us about the bone fractures, and also it helps with the different type of cancers in more detail. And X-ray also does that, but not as detailed as the CT scan. And so it also being used for the infections, and but it is fast, but it's not as fast as X-ray, but it is available in many places, imaging centers, and also it is very usable in the emergency room ER centers. And it is quicker than MRI, and it is preferable by many doctors and the clinics. MRI it is showing more detail of the soft tissues and the brain than X-ray simply can do, or a CT scan can do. And so it is a tool to use for disorders or diseases of the central nervous system, such as multiple sclerosis, and or someone has a stroke, MRI could be a quick way to study that. And but it is taking a longer time than CT scan, and therefore at the ER centers, MRI is not the primary choice. Ultrasound can be used for different um, purposes, uh, and like cancers, and also ruling out some type of disorders. And it we are very familiar with the monitoring pregnancy. Ultrasound is very useful, but it also can be utilized to study the soft tissue disorders, but also can be used to study the bone fractures and joint dysfunction. And PET scan is also an imaging tool, and it can be used for the central nervous system disorders. And again, it is time consuming, and it is not something that can be done fast. And it is being used for conditions like Alzheimer's, Parkinson's, or also can be used for people that have epilepsy and seizures to see that how the brain function. Now we go to diffusion tensor tractography, which is a newer type of imaging tool, and it has uh, very um, more of understanding how the brain function or not function correctly, and it has a set of um, control imagings, which uh, has the data of how the tracks run and how they look like, and it has the thickness and the length and the origin and the uh, targeting areas that those tracks go. And so they compare the normal with the abnormal brain, and it is not uh, being used frequently at this time, and possibly is a timing and also expense are the two major drawback of using this technique. And but it is very useful if someone has been involved in the whiplash accident and the head trauma, and it gives us a better understanding of how the brain is doing. There are many, many, many tracks in the central nervous system, and we hardly know the percentage of those tracks or understanding the function of the tracks that we know fully. And so there's a long way to go in neuroscience to have a complete understanding of all of those tracks and functions. There are some major tracks that uh, we know, and we understand those better than many other ones. And some of those are motor tracts, some of them are sensory tracts. And these are uh, motor tracts that are found in uh, the spinal cord, but again, not all of them. And one of them is the corticospinal tract. As the name suggests, it is coming from the cortex and it goes to the spinal cord. Generally, they think and or they talk about this tract that it is a motor tract, uh, which is not totally correct, 100%, because the corticospinal tract not only controls the motor system at the spinal cord level, it also controls the sensory autonomic nervous system as well. And so it has a very complex function and regulatory impact on the spinal cord. The other tract is pontine reticulospinal tract, which the name also suggests that it is coming from the pontine portion of the brainstem. And it is a reticular formation, which is, again, a very complex and primitive uh, circuit that it exists in the brainstem and more going up to the diencephalon of the brain. And the function of the posterior spinal tract, it is major function of it. Mainly, it is motor function, proximal extensors, which are dealing with the posture and balance. Besides the reticular formation that we have in pontine, we have in the medullary as well as the mesencephalic portion of the brainstem. The medullary reticulospinal tract, as it shows on this picture, it controls the mainly the flexor part of the motor output of the spinal cord, but also it controls the autonomic nervous system, which is very adjacent to that tract in the spinal cord on the lateral side. And so medial reticulospinal tract has a different function than pontine reticulospinal tract does, but both of those are considered as the primitive motor control center in the central nervous system. Vestibulospinal tract, again, controls your balance and gait, and it is also one of the primitive motor centers in the central nervous system, which not only projects up and to the higher center and to the side, to the cerebellum, down to the spinal cord, also control the extensor proximal part of the body, and by sending the axons down to the ventral funiculus, and eventually it will control the motor output of the spinal cord. The vestibulospinal tract not only controls the motor output of the spinal cord, but also send the axons up to the higher center to deal with the eye movements, as well as it goes to the cerebellum to have a more complex control of the gait and balance. Ruberospinal tract, which comes from the red nucleus to the spinal cord, originate from the midbrain, and it is found in the lateral aspect of the spinal cord in the lateral funiculus, which indicates that it is more influential tract to the flexors than to the extensors. It is a primitive type of tract compared to the corticospinal tract, which does similar than the corticospinal tract, but the ruberospinal tract is more of type of very basic control and controlling the flexors more than the extensors. The tectospinal tract, which comes either from superior colliculi or inferior colliculi coming down to control more of the upper and the midline of the body, more so to control the reflexes from the visual or auditory inputs to deal with the movements of the neck and the upper extremities. Beside motor tracts, we have sensor tracts in the spinal cord. Those are the major ones. One is called the spinal thalamic tract, which are this ascending tract to the higher center, and as the name suggests, is coming from the spinal cord and ends in the thalamus. But along the distance that is going up, it gives the several branches, which are called collateral branches, to the brainstem centers and also to the hypothalamus and reticular formation along the distance. And it is carrying pain, temperature, and some of the light touch to the higher center, and it is the information that goes up to bring the alertness to the cortex at the time of painful experience. A spinocerebellar tract, there are several of those, and which are coming from the spinal cord to the cerebellum. It carries the proprioception and it informs cerebellum where your posture and your body joints are within the space limit, and it gives the ability to the cerebellum how to balance, coordinate your body based on the sensory information coming in. A spinal reticular tract is another sensor tract that goes up to the reticular formation to let the reticular formation in the brainstem know that, again, the positioning of the body and the motion of the body is, and so the reticular formation can help the spinal cord as a feedback to modulate the motor output and balance. A spinal vestibular tract, as we mentioned before, again, this vestibular system, which controlling the spinal cord for many extensors output, it is the information comes from the spinal cord to the vestibular system as a feedback that how the vestibular system is functioning, as well as it is the information that the vestibular system can use to control the motor output at the spinal cord. And so uh, these sensory tracts, which are carrying information up, it is carrying information up to let this higher center of the central nervous system know for feelings, as well as it is uh, uh, dealing with the feedback, how the higher center is doing as far as the controlling the motor output at the lower level of the central nervous system. But we talk about the spinothalamic tract, and we are going to be looking at these two terminologies because the paper, the abstract that we are referring to, they talk about these two names, and one of them is allodynia, and the other one is the hyperalgesia. And based on IASP definition, allodynia, it is the pain due to stimulus that does not normally provoke pain. So if somebody is having experience of touch like on the skin, it should not be painful. If it is painful, it is not normal, which is a paresthesia, and in that case, it is felt as a pain and which should not be painful, and is referred to allodynia. Whereas the hyperalgesia is a type of sensation which is exaggeration of the pain. And well, if I poke someone's hand, it is going to be, it might cause a pain. But if that pain is exaggerated and it felt at higher level than norm, that is called hyperalgesia.